So this is a bit of a now for something completely different sort of talk, because I'm talking about global health and I'm talking about population health and health policy issues, which are a bit removed from clinical cardiology. So bear with me a bit. If I talk about anything that's a bit unclear, please interrupt me and ask for clarification, but I'll jump straight in. I want to talk about basically three types of things, and the learning objectives are as follows. First, to give you appreciation for global trends and inequalities in cardiovascular outcomes and drivers of future disease burden. Then to summarize some of the work from the Disease Control Priorities Project and to be able to list at least 5 cardiovascular disease interventions that are cost-effective and feasible in nearly all countries. So sort of the baseline, the bar for interventions in all countries, regardless of development status. And then to appreciate some of the challenges to scaling up cardiology services and opportunities brought about by COVID-19 to actually accelerate that. So in full disclosure, I have support from these fine people for this work, as well as Greg said, other grants that are more cardiovascular disease focused. So let's jump right in to talk about what is going on with the global cardiovascular disease situation. So let's start with some basic facts. There were about nearly 18 million deaths from cardiovascular disease worldwide in the year 2017. And that is about a third of the deaths in the world. And importantly, that includes adults between the ages of 40 and 79, which you might call premature. These deaths are, more preventable than deaths at older ages. And you can see from the bar graph on the right that the red, the cardiovascular disease deaths here, about 10 million, represent a significant amount of deaths in that group, as well as in the older age group. And so this is really a target for policy in global development in the current era, is to reduce deaths amongst adults who are of working age. Specific cardiovascular diseases that contribute to this include ischemic heart disease or coronary artery disease, which is about half of these deaths. So about 5 million deaths under the age of 79, stroke, which is about a third of these deaths, and then other causes like cardiomyopathies, rheumatic heart disease, and things like that, being about a sixth of deaths. So it's a big deal because, if you can explain a third of all the deaths in the world with a few diseases and a few risk factors, that suggests that those diseases and the interventions for those diseases have a huge impact, could have a huge impact on global health. Now, as Greg has shown us in previous work, the reasons for the size of the global cardiovascular epidemic are complex and include at least 2 types of factors. One is, of course, changes in age-specific incidence and mortality rates, which, are a factor, epidemiological factors mostly. But there are other factors, demographic factors at work that are also making cardiovascular disease more and more important over time. And this graph shows changes in total cardiovascular deaths between the years of 1990 and 2013 that can be decomposed into 3 factors: changes in population growth, driving the size of population exposed to cardiovascular disease, and similarly changes in population age, median age of the population, as well as changes in age-specific death rates from cardiovascular disease. And so if we take an example from southern sub-Saharan Africa, a region I know well, between the years of 1990 and 2013, there was almost a 60% increase in deaths. So that equated to about 50,000 excess deaths from cardiovascular disease in 2013 as compared to 1990. And that can be broken down into mostly, you see here on the x-axis, on the y-axis going up, population growth and aging, which is offset a little bit by reductions in age-specific death rates. And so the sum total of these factors means that there's an increase in deaths, even at the same time that rates at any given age and sex are actually going down because demographic pressures are driving these things up. So we redid, using slightly different methods, Greg's analysis with more recent data, showing similar sorts of things. Basically, the sum total of this is that there's significant demographic headwinds for reducing the number of people dying of cardiovascular disease. And so at a global level, looking at under 70 deaths, you had about 2.6 million deaths in 2000, 3.4 million in 2016, which translates to an average annual rate of change, 1.6% increase per year. And when you break that down, I'll just draw your attention to the last 2 columns here. That is composed of demographic shifts of about 2.5% per year increase in deaths related to population growth and aging. That's offset by about 1% from reductions in age-specific death rates. So the net effect is about 1.6% increase in deaths every year. And so it's a bit of a challenge to define what are appropriate targets for cardiovascular disease, because you can be making good progress on reducing an individual's risk of death over time, while at the same time seeing more and more cases and more deaths from cardiovascular disease. And this is something that's important to explain to policymakers, because this is different than, for instance, HIV or maternal mortality, where the absolute number of deaths going down over time is an important policy target. But for this, we're looking at different types of targets. Now, in epidemiology, in clinical medicine, we care a lot about the sort of age-specific rates, but finance ministers and planners care a lot about the counts, the crude, numbers of cases, and those are as important to communicate, and trends in those are as important to communicate as the actual age-specific rates themselves. This is another look at ischemic heart disease and stroke in the context of other non-communicable diseases and injuries, and what I'm showing here is the average rate of change in age-standardized mortality, so those age-specific death rates, with more negative being better and positive being worse over time. And this is showing basically that there's a wide distribution in rates of change in ischemic heart disease and stroke across different country groups, with some country groups experiencing fairly negative or pretty astounding rates of change, and others experiencing actually increases in mortality over time. And this is concerning because if you think about it, when those rates are changing at such different rates, positive versus negative, you have a divergence over time in outcomes. So there's actually increased inequality in cardiovascular health over time. And again, this is in contrast to the situation with infectious diseases and maternal and child health conditions, where we're seeing a convergence or reduction in inequality globally over time. And so this particular trend for non-communicable diseases and for cardiovascular disease in particular is quite concerning and suggests more effort needs to be made to target policies to regions which are lagging behind or having increases in death rates. Now, this graph shows a slightly different view and a slightly more concerning twist, which is when you look at more recent trends, rates of change over the past several years as compared to, you might call a more optimistic period, the period 2000 to 2010, and you plot those rates against each other, what you can see is that, and this 45-degree line means there's sort of agreement between those two measures for any given, each of these dots represents a country. What you see is that there are a number of countries where mortality is actually accelerating, so they're doing better in 2010 to 2017 than they were in 2000 to 2010. But the majority of countries are actually decelerating rates of decline in mortality. So if they were going at minus 2% per year in 2000 to 2010, maybe they're going at 0 now. And so there's this deceleration warrants some further unpacking, suggests that there's things going on with risk factors, perhaps health systems, perhaps economic factors, but certainly a worrisome trend, because we have set targets for global cardiovascular disease reduction based on assumed feasible rates of change that are historically observed in this period that's a bit earlier. Now we need to think about what are appropriate targets for an era, for instance, where there's a lot less economic growth, where there's other shocks to health systems, and then there is the question of why these trends were decelerating prior to COVID-19. Perhaps there are things like risk factors, obesity, and other sorts of things that are kicking in sort of cohort effects or younger ages, causing the slope of these particular mortality trends in particular countries to go up. And then, of course, there are some countries that have actually reversed progress. There's not too many, but certainly the overall trend is that the world is lagging behind where it could have been compared to historical trends. The other thing I'll point out is that there's a common misconception in global health in a lot of circles that heart disease is a disease of rich people. It's a disease that affects affluent populations where they eat too much and they smoke too much and they have too much money and time on their hands and they don't move enough. And that's true to some extent, but also your risk of dying of cardiovascular disease, and this is looking again at age-standardized death rates, is actually highest in the lowest income countries overall. There's obviously a lot of factors here. This is not a perfect correlation, but generally speaking, what you see is a higher risk of dying of cardiovascular disease in poor countries. And that may strike people who've actually traveled to low-income countries and say, well, I don't see the same sorts of patterns here because, the risk factor burden is much different in low versus high-income countries. And this is borne out in large studies like the PURE study, which I'm showing here, where the NR Heart Risk Score, which is like a global assessment of cardiovascular risk, is higher in high-income countries and higher generally in urban versus rural versus urban areas in high-income countries. You see this and know this well, but the situation is reversed where overall cardiovascular risk is lower in low-income countries, and in particularly rural populations, which make up the majority of the population. So if risk factors are lower, what's going on? Well, a peer study also looked at case fatality from cardiovascular disease. And what you find then as you look at all cardiovascular outcomes together is that there's about a sevenfold increase in the risk of death from cardiovascular disease in low versus high income countries. And so if risk factors and disease incidence aren't explaining a lot of the disparities in mortality, it's probably case fatality. And so if we think about what drives case fatality, well, it's things like treatment. So this is another study from the Pure collaboration looking at the use of secondary prevention for coronary heart disease or ischemic heart disease and stroke. And what you see here is that the proportion of the population taking 3 or more drugs, combination therapy for ischemic heart disease and stroke varies widely across countries by income status. And so, for instance, if you look at the proportion of the population in high-income countries taking 3 or more drugs for ischemic heart disease or stroke, you see that number is 30 to 50%. Not great, but definitely an accomplishment. But when you look at low-income countries, you see numbers that look more like 0 to 5%. So most people are taking exactly 0 medications after having had a cardiovascular event. And so if you think about the impact that we all know we've seen from clinical trials for secondary prevention on reduction of mortality and further events, then this really shows how gaps in health systems and ensuring access to care, ensuring access to basic pharmacologic treatments really can be driving case fatality and overall mortality patterns across countries. And the reality is when you take a step back from these numbers and look at health systems overall, the situation is one where health systems in a lot of countries are oriented towards care for acute and episodic needs. So things like, malaria, things like child immunizations, antenatal care is really what they're doing fairly well, but they're not oriented towards chronic disease care management, especially complex referral and counter-referral systems that you need for cardiovascular diseases. And the upshot is that there's low availability of high-quality chronic disease care for cardiovascular disease, as well as other non-communicable diseases. And this, in part, is due to some factors that are systems factors like, supply chain management, overly centralized management distribution systems. So in rural, far-flung places, there's literally no medicines. There's no ACE inhibitors or beta blockers around. In many health facilities, there are insufficient financial and human resources. So what ends up happening is that there are, in many countries, and this is a picture of a health facility in rural Uganda, where it was a couple of years ago, and there are private health facilities and pharmacies that do sell these medicines, but you have to pay for them and you have to pay out of pocket. And patients in these parts of, in this case, Uganda, don't have a lot of money and don't necessarily want to pay for medicines for life for a disease they don't have any symptoms from. And so there's a lot of gaps and challenges to getting people on guideline-based therapies. And of course, there's a sort of other thing going on, which is that oftentimes you have parallel sort of quasi-private systems of care that serve civil servants and other elites. They're basically referral services in capital cities that are maybe academically affiliated that serve a niche population and consume a disproportionate share of public resources. And so from an equity standpoint, this is especially problematic because you're not dealing with cardiovascular risk at the source. And the upshot of all this, again, is that, you look at a region like sub-Saharan Africa, which doesn't have tons and tons of cardiovascular disease right now, mostly because populations are younger and healthier. And over time, those cardiovascular disease is projected to overtake other causes of death, in this case, by 2040. And this is data from IHME from forecasting in 2016. And, again, you see in 2000 what people thought about as health issues in Africa: diarrhea, pneumonia, HIV, TB, malaria, all going down well because of all the things we're doing really well to reduce those diseases, and cardiovascular disease, diabetes, cancer racing up to the top. And some of this, again, is demographic, but a lot of it actually has to do with the fact that we're not controlling risk as well as we could in these parts of the world because health systems are not receiving the investments and the sort of priority interventions that they need. And on that note, I'll turn to interventions, but maybe I'll stop in case there are any questions on the epi side of things.
David, I think given the number of people we have, why don't you continue, and we'll keep time at the end for questions.
Okay, great. So let's jump to what can we do about the situation? What are priorities for global health, particularly in countries with such acute resource constraints? So I'll basically go through a summary of findings from the Disease Control Priorities Project in this part of the talk. And first, start by giving you a bit of background on the DCP project. The first DCP publication was featured as part of the 1993 World Development Report, which was a report by the World Bank on usually, development economics and development issues. This was the first one focused on health, and it was led by a man named Dean Jameson, who used to be a professor here, is now since retired, and that report was influential in global health in a number of ways. It sparked popularized the use of cost-effectiveness analysis in global health and in priority setting in low and middle-income countries. The disability-adjusted life year as an outcome measure was invented as part of this report. The Global Burden of Disease as a risk factors project was spawned as part of this. And so it was a very important time for global health and a lot of work that people at the UW are intimately involved in. And importantly, it was one of the factors that influenced Bill Gates in getting into global health and seeing the high opportunities for low-cost, high-impact investments in less developed countries. That was a book and a companion volume called Disease Control Priorities, and that was updated in 2006 with the second edition of Disease Control Priorities, or what we call DCP2. And that was, one big book and a Global Burden of Disease companion volume. And DCP3, which was an update published over 2015 to 2018, was not just one book, but 9 books, which comprised a pretty massive effort over really 10 years before 2018, with over 500 authors, 230 plus peer reviewers, editors of each of these volumes, and 172 chapters that covered really all aspects of global health. There's an entire volume devoted to cardiovascular and respiratory diseases. There's a volume devoted to cancer. There's volumes devoted to things like surgery. So not your typical global health sort of stuff. There's, of course, stuff on, child health and infectious diseases, but a lot of what Disease Control Priorities has to say about global health speaks directly to emerging global health challenges. There's a whole section on pandemics, interestingly enough, that has some lessons for today, we'll put it that way. And one of the main outputs from DCP3, the publications that were released over the last few years, is the idea of essential packages of care. And an essential package within the context of DCP3 is essentially a set of lists of recommended interventions. And those lists are oriented around particular health topics or professional communities. So for instance, there's a maternal health package, there's a cardiovascular disease package, there's a cancer package. And these packages seek to identify all the interventions in global health that fulfill 3 basic criteria. 1, they provide good value for money, so they're cost effective. 2, they are feasible to implement in low and middle income countries. And 3, they address a significant burden of disease in low and middle income countries. And so these criteria actually winnow the landscape of potential interventions quite a bit. There's obviously further prioritization for countries with very low resources, but this gets you into the ballpark of the high priority interventions for most countries. And these recommendations, again, people were invited, leaders in global health, leaders in global cardiovascular disease, and others were invited to synthesize data, drawing on systematic reviews of economic evaluations, burden of disease data, clinical trials, and other sources of data, including, importantly, judgment about what might be feasible and what to make, particularly in settings where there's not very good data or not strong evidence for intervention. So when we think about cardiovascular disease intervention points, the central challenge, I think, is that, as we all know, cardiovascular risk inherently increases with age. And because we've made such great progress globally on access to contraception, which reduces fertility rates and child mortality and young adult mortality from infectious diseases, we have, populations that are growing larger because death rates at lower ages are going down. And so you have more people, and therefore more people exposed to deaths in middle and older age groups. And combined again with population aging, which is a product of the reduction in fertility, you have more old people and therefore a greater share of cardiovascular deaths because the population is older and more exposed to cardiovascular risk over time. And so if you think about intervention points way over on the left, if you want to reduce age-specific rates of cardiovascular death, you might think about a sort of a continuum or spectrum of risk, where at the very far end you have things like income and education, social determinants of health, which influence but don't totally determine behaviors like diet, choice to use tobacco, as well as the environment people live in, such as if you're living in an urban environment in a low-income country or low-middle-income country where the air quality is very poor. Those things influence cardiovascular risk. And these sorts of behavioral and environmental risk factors then lead to physiologic changes, increased blood pressure, increased BMI, and other sorts of things. And these together I would call risk factors, but they're more distal versus proximal risk factors. And they have different time lags between intervention and health impact. And of course, physiologic changes lead to changes in age-specific cardiovascular disease incidence, which then leads to mortality through case fatality. And so these orange highlighted text boxes are showing some potential points of intervention, well, all the way from reducing sort of the environment in which people live to giving people drugs and devices to reduce case fatality. And again, the time lag here is significant because you can give people medicines right at the point of care for an acute event and reduce their chance of dying right then and there. Changing people's diet, getting them to exercise more, takes a lot longer. And so those interventions have a sort of time lag that's hard to communicate to policymakers who are used to quick wins and used to doing something today and reaping benefits before they're reelected. So this is quite a challenge to deal with chronic disease targets and policies and communicate the short and medium-term benefits of investing in those types of services to people who are accustomed to short-termism in the way they think about health. So we in DCP3 thought about sort of a typology of policy interventions to address cardiovascular disease and other diseases, basically by breaking down the world of interventions into two groups. One you might call intersectoral policies, which are policies that are implemented by sectors that aren't health, so ministries of finance, treasury, education, transport, and other sorts of things. And they have influences on health, but they aren't actually implementing health services. And so you think about safe roads that reduces risk of injury. You think about tobacco taxes, that's a finance minister, a treasury policy, and reduces smoking prevalence, but it's not under the purview of the health sector. But they're important because in general, these sorts of policies reduce the behavioral and environmental risk factors that over time lead to cardiovascular disease incidence. More proximally, though, the health sector and health sector policies are responsible for addressing physiologic risk factors like high blood pressure and lipids, as well as disease outcomes themselves, both death and disability and the sort of intangible pain and suffering associated with that. And so we talk about interventions mostly as the sorts of risk factor reductions as well as clinical interventions to address outcomes. We acknowledge that there are policies that improve access to care, uptake of health interventions, and of course the quality of delivery of those interventions. But we think of them as sort of architectural features of the system that require special attention that oftentimes are cross-cutting. So quality improvement measures often have lessons across a range of diseases. And so we define interventions as specific technical approaches to addressing these outcomes themselves, but then can be modified, for instance, by improved access or quality of care. And this is showing you, and I won't go through this in great detail right now because I'll summarize the high impact areas in a moment, but this is a screenshot of the first of two slides of the DCP3 cardiovascular disease essential package. It's about 35 interventions or so. And you can see here from left to right, they're organized from, on the left-hand side, fiscal and intersectoral interventions, sort of things that aren't outside in the health ministry's purview. And then on the right-hand side, personal health services, clinical services that are organized into community, primary care, first level of community hospitals, and the referral or specialized hospitals. So this first bit is all about risk reduction that applies to all cardiovascular conditions. And there's a second set of recommendations that are targeted towards specific disease conditions like ischemic heart disease, heart failure, diabetes. And you can see that the sum total of all those things is the shift as you get into the disease targets towards more primary care and then hospital-based care. And so there's a recognition of the importance of prevention, but also of treating with high-value acute interventions, and particularly the importance of investing in health facilities, primary care centers, and first-level hospitals. Now, I gave you just a screenshot of a lot of interventions, but I will summarize these interventions into two groups. Again, intersectoral or public health interventions, and then personal health services or clinical interventions. And I think subsequent modeling work we've done based on this has shown that there are probably 7 or 8 interventions that far and away give the highest population impact in terms of numbers of lives saved over a given period of time. On the intersectoral side, by and far the most important thing is tobacco taxation. It turns out that for reasons that I'll get into a bit later, there are tobacco is becoming more affordable around the world rather than less, despite tobacco taxes being in place. And so this is still a huge target for many countries of the world. Clean air laws, so bans on smoking in public places. And then mass media campaigns to change hearts and minds. These things you don't think of as typically being very effective, but in the case of things like tobacco control, they actually are really, really impactful, surprisingly. On the personal health services side, I think there are probably 4 interventions that stand out. One is secondary prevention of ischemic heart disease and stroke using combination drug therapy, probably the largest number of lives saved, over time. And then followed closely by primary prevention, which is basically blood pressure and lipid control. Interestingly and importantly, we know a lot about heart failure now and chronic heart failure management. And so, combination therapy to reduce, chronic heart failure mortality is quite impactful because a large share of cardiovascular deaths are mediated by heart failure rather than, thrombotic events. And then importantly, we found through a lot of this analysis that there's an important role for treatment of acute heart failure. And I know that there's the party line in cardiovascular diseases that diuretics don't reduce mortality, and that's maybe true in a high-income clinical trial setting. But the ability to identify patients with acute decompensated heart failure, to stabilize them and to get them on guideline-directed medical therapy is really an important way in a low middle-income country context because people don't receive a lot of care before they develop, kind of incident heart failure. And so when prevention has failed, you need to have strategies for getting people on chronic disease management. And so this sort of stabilization role of acute heart failure treatment is an important part of addressing heart failure disease burden. So again, these factors, these 4 interventions probably address 80-90% of cardiovascular mortality if you add them all up. And so they represent, I think, the low-hanging fruit and probably most important initial intervention targets for cardiovascular disease. I'll just give you a screenshot of the summary paper from the cardiovascular disease volume in DCP3 for those who are interested. This is from Lancet 2017. It's a nice long review, including that package of interventions in more detail, as well as review of trends and health system factors and other sorts of things. Now let's jump to the most challenging and interesting, I think, part of this talk for sort of science, which is how do you then take action on cardiovascular disease when we know what to do, but we face a lot of gaps in delivery of care? Well, I'll start by talking briefly about some of the challenges and opportunities for rollout of intersectoral and public health policies, the things like risk factor control, tobacco, diet, lifestyle, those sorts of things. It's true that not even in low and middle income countries, but also in high income countries, these sorts of policies have not been sufficiently implemented. And so you have a situation, for instance, where taxes are not keeping pace with income growth. So countries do have taxes in place for cigarettes, but those taxes are too low and they're not increasing fast enough to account for growth in GDP and growth in personal income. And so in many countries of the world, probably more than half of countries, cigarettes are more affordable now than they were 10 years ago. So more needs to be done to increase the size and rate of increase in taxes. And then another really important factor is, and probably not surprising to many of you, is the interference that industries run in countries that have this particularly economic incentive to be involved in sort of cardiovascular risk factor issues. So for instance, in southern sub-Saharan Africa, countries like Malawi and Zambia, tobacco growing and sales are a huge part of the economy. I think like 15-20% of GDP in Malawi is due to tobacco. And so it's really challenging when you have a need for global development and a need for economic growth that's being driven by something that's so harmful. And so industry understands this and is very cogent in making these arguments to finance ministers and others to say we don't need to do these policies because they're going to hurt your country's growth. And, presidents and prime ministers and finance ministers care about economic growth above all else. And so they fight very tooth and nail to keep policies, public health policies, at low levels. And then another example is, of course, many of you know about the sugary beverage situation in Latin America. This was the subject of a series of articles in the New York Times a couple of years ago showing the interference in foreign investment from the beverage industry in Central America and Mexico, making it hard to, roll out policies to address diabetes risk. This requires a lot of civil society and advocacy pressure on governments. And so I think because many people don't realize in many countries, the importance of these risk factors, there's not a lot of pressure on governments to counter industry effects. And so they end up sort of giving in or towing the party line with what talking points are given to them by industry. And so really what's needed for implementation for these sorts of policies is greater civil society and patient advocacy, as well as international collective action, which is sort of the international community coming together and saying these are standards. So we have this for tobacco control. We have what's called the Framework Convention for Tobacco Control. But we really need this sort of thing for dietary risk factors and other sorts of increasingly important drivers of cardiovascular mortality. And of course, as many of you probably can guess, the argument for Treasury secretaries and finance ministers is that doing these sorts of policies reduces disease incidence and saves the system money. And some modeling that we did based on DCP interventions suggested that without implementing these policies, you would have medical costs that are probably 25% higher because of increased rates of disease incidence, even over a short time period, like 10 years. Unfortunately, there's still quite a few evidence gaps that we face, and these are known to many of you who work in these areas of risk factor, preventive cardiology. We don't really, at least in my reading of literature, have a really great handle on evidence-informed dietary policy. I mean, we talk about things like trans fats and salt intake, but those are fairly minor contributors to cardiovascular risk compared to macronutrient intake and other sorts of things. But we don't really have a coherent approach to diet, at least one that has obvious policy levers and ways of intervening in cost-efficient manner. And similarly with physical activity, everybody knows you need to be more active, but sort of the trajectory of development is that as countries get richer, they get more sedentary, and the labor force shifts to being more sedentary. And so you're fighting again a lot of economic and non-health sector headwinds here. And so countering that and also having cost-efficient policies to change the built environment to increase physical activity is a big evidence gap too. And so diet and exercise, again, are some of the most challenging aspects, some of the obvious points of policy intervention, but a lot of gaps on how best to do it in a manner that doesn't break the bank. So let's jump now to the clinical interventions, and I'll talk very briefly about the cost of these things with the U.S. as a foil. We did cost modeling of the DCP3 interventions a couple of years ago and looked at low-income countries, which comprise about nearly 1 billion people, and lower middle-income countries, which comprise about 2.5–3 billion people. So sort of the lower bottom half of the world's income distribution in these two groups of countries. And that at full population coverage, so 80% coverage of the population for these interventions that I showed you, that would add up to about $20 billion a year. And low-income countries are about $21 per capita. And in lower middle-income countries, about $100 billion a year, or 37 per capita. And, you might think that those hospital-based services are the most expensive thing. That's what makes this package so expensive. But actually, it's the primary and secondary prevention of cardiovascular disease interventions, basic drug therapy, because the numbers are so large of young middle-aged adults who are exposed to risk. Hypertension affects over 1 billion people. And so there's a lot of demand for these interventions, particularly on the preventive side, that drives up costs. And this is super important to think about these costs and the size of these costs in comparison to spending on cardiovascular disease in the U.S. I won't go around the room and ask people to take a guess on how much we spend on cardiovascular disease in the U.S. But basically, in 2016, it was estimated by HME that about $260 billion was spent on cardiovascular disease. So we spent in our country more than twice what 4 billion people in the world spent on would have spent on cardiovascular disease care if they had universal access to these basic therapies. And that number works out to about $800 per capita, which is quite a bit higher than $20, $30, $40 per capita. And now I know that things are more expensive in the US and purchasing power and all these sorts of things, but even adjusting for all those factors, you're talking about huge differences in spending, and raises the question about if our mortality patterns aren't massively different, where is the value for money in what we're doing in the US? And how can we ensure better and more efficient spending of this quite substantial amount of money? Now, I'll summarize some other intervention implementation issues, broken down into financing, which is a really important component of costing, delivery, and what you might call international action. The first group, financing. So some of the main sort of opportunities for intervention implementation are, one, ensuring that there's sufficient public resources for health. Because, and this is not just true of cardiovascular disease, it's also true of a lot of health conditions, raising enough money to pay for healthcare is a real challenge, particularly in countries that have insufficient economic growth or have factors sort of against them in terms of raising GDP. So there are challenges there, but a lot of countries aren't getting the kind of resources to help they could by improving the efficiency of taxes, for instance, in social health insurance. There's also a really important role for reallocating resources towards high-value care. And so it turns out that there is a substantial amount of money being spent on things like expensive cancer chemotherapies that are not effective, or dialysis services in a lot of countries, including some poor countries. You might be surprised. And then fossil fuel subsidies is an example of a non-health sector cost that's just causing harm. It adds up to about 6% of global GDP. And so governments are spending a lot of money on things that aren't really achieving a lot of health goals. And so reallocating those resources without even increasing budgets can have a huge influence on the amount of money available for cardiovascular disease care. On the delivery side, I think there's a few things that are really important. And again, there's a lot of different factors around implementation we could talk about, but these are three that kind of, to me, seem to be urgent. One is to figure out better ways of increasing demand for care. And so because, CVD is largely asymptomatic until it's too late, there needs to be a better approach to targeted screening and case finding, particularly in settings where access to advanced treatment is low, but also even basic treatment of things like blood pressure is low. So integrating screening as well as high quality treatment is a real challenge, particularly when people don't have in their minds that you need to take medicines when you don't feel sick. It's a real challenge. Modernization of supply chains. So this is things like the drones that Amazon has flying around. I mean, these are things that actually, there have been huge gaps in access to medicines in many countries, especially landlocked countries that have a large rural population. These technologies that we have now in the last few years can really revolutionize this. And these, I think, really exciting opportunities to improve access to cardiovascular care and reduce disparities within countries. And then the third thing, I think, is having a serious conversation about tertiary care and about investments in tertiary services. And of course, I'm speaking to a bunch of cardiologists, people who work at a quaternary hospital, and so this is our bread and butter. But, the primary care movement really just does not love this idea. And yet for cardiovascular disease and other non-communicable diseases, there's an important role, particularly for cancer, actually. There's a really important role for investing in tertiary care services to ensure all across the continuum that you're doing the right thing by patients. Now, international action, a couple of things that I think are really important to supplement these financing and delivery strategies that I've listed above. At a domestic level, international action to support this would be sort of global research and development on improved technologies. And so this is not so much a new drug for, cholesterol, but maybe fix those combinations of existing drugs to improve adherence and improve delivery, make supply chains easier to manage. And also support for population and policy research. So networks of different academics and policymakers in different countries learning together on how to roll out programs and do so in a cost-efficient manner. So the last bullet is for the international community, donors like, U.S. government, the Gates Foundation, others, to really support the growth of knowledge for countries. We're not talking about paying the bills, medical bills for people in low-income countries to get cardiac stents. We're talking about supporting global public goods that improve health for all countries. And this is an important supplement to domestic action, particularly in the financing and healthcare delivery side. Now, I'll highlight this tertiary care thing just a bit more, because I think this is an important area to discuss for a cardiology department at an academic center. So let's think about cardiac surgery. And here's an example of the rollout of cardiac surgery, valve surgery in Egypt a few years ago. The reality is that in many countries, cardiology and cardiac surgery exists, but it's limited. It's focused, for instance, on academic hospitals, tertiary hospitals in capital cities, urban environments. And so that doesn't really get out to the populations who need it the most. It stays pretty localized and at low scale. And, as many of the fellows in this room know, there's a huge lag time of producing specialists. After you get your bachelor's in medicine or whatever, it's another 10 years before you can become an interventional cardiologist or a cardiac surgeon, plus or minus. And so there's a real challenge to getting specialized care up and running quickly, because it takes a long time to train people and it takes a long time to build facilities. And so if you want to have cardiac surgery running and operating at reasonable scale in 2030, you need to start now finding people to participate in those programs and finding, exchange programs to train people. And this is, I think, one of the really important opportunities for cardiologists and academic cardiologists in developed country settings to participate. And I know a lot of people in the department are already doing this, but I think those who are interested in global health, this is probably the lowest hanging fruit to bring expertise and to share knowledge, because, I work quite a bit in Uganda, and Uganda has really kind of led the East African region in cardiac surgery and specialized cardiology services. A few years ago, they didn't have hardly anything going on in terms of surgery and interventional capacity. And now they're actually doing quite a bit. And that was the result of about a 10-year investment from Cleveland Clinic and Case Western, as well as some Brazilian colleagues, to really build capacity to train interventional cardiologists, to train surgeons to do these procedures that are quite complex, and importantly, to build local capacity rather than to have medical missions parachuting in and out. And so that is that investment that takes time. And on the left-hand side here, you see what that looked like for valve surgery in Egypt, where you maybe started at a low rate in 2009 of fairly, some mitral valve procedures, but over time you had a significant increase from a couple hundred to more than 1,000 procedures per year. With the complexity increase, you see mitral valve repairs increased over time, and balloons also increased over time. So these things take time to scale up, but they can happen over a defined time period with sufficient investment. But the training needs to start early, because that's the major bottleneck to rolling out specialized care. Now, I'll conclude by just reflecting for a few minutes on COVID-19, because, these slides I could have given 3 or 4 years ago, and they would have been, probably enough for most people. But now we have a new shock to the global health system and to country health systems, particularly in countries that have the least resources and capabilities to deal with COVID-19. And so, a lot of people have talked about the negative impact of COVID-19 on cardiovascular disease and on health generally. And I think that's definitely true. And we have much ink that's been spilled in the literature on, excess risk of cardiovascular disease during the COVID pandemic and all this sort of stuff. And this is all very, very important. But I think it's also important to really move the conversation forward and say, what opportunities does this particular shock provide to move forward on the global cardiovascular care delivery agenda? And what lessons might that even have for countries like the US? So the way I think about it in my simplistic general internist mind is that there's probably 2 types of things going on here. The first is that there are deaths from COVID-19 amongst people with cardiovascular disease. And there's cardiovascular deaths, heart attacks and strokes during the COVID-19 pandemic. And you have to disentangle those a bit. On the one hand, people who have cardiovascular disease who die from COVID are known to have excess risk, and that is just a sad fact of life. The intervention here is to treat and prevent COVID-19, and we're working on that. In the long term, sort of for the long game for the next pandemic, there's an agenda to reduce cardiovascular disease incidence and severity through things like blood pressure and lipid control. But those will not really have any measurable impact on outcomes during this pandemic, at least as far as I can tell. So really, the way of thinking about COVID-19 amongst people with cardiovascular disease is not too different from the way we think about global cardiovascular disease control and pandemic preparedness and mitigation in general. So there are some new things around the margins, like improved diagnostics, a lot of basic science, but on a population and policy level, this is largely a fairly known, I think, and understandable issue. On the other hand, we have the issue of cardiovascular deaths, excess cardiovascular deaths during COVID-19. And here, I think, there are probably two types of factors that overlap: patient factors and health system factors. And on the patient factor side, you could think about, people stuck at home and stressed out and increasing the use of tobacco and becoming more sedentary and those sorts of things. Those factors may have some influence on cardiovascular mortality in some people over time. Those aren't really under the purview of the health system. On the other hand, the health system and governments generally have a huge impact in how healthcare is delivered by doing things like lockdowns and necessary measures like canceling elective procedures, canceling carotid endarterectomies that aren't necessarily urgent. And there's some stuff in the middle, of course, that are both patient and health system interaction factors like adherence to medications or wanting to go to the hospital because you're having chest pain. And so those factors, at least because they're partially under the health system control, are opportunities to redesign health systems to improve cardiovascular care and circumvent some of these really challenging issues that we're facing around excess mortality. Now, some reflections here. Just a few thoughts from an outsider's perspective. It seems to me empirically that we have pretty substantial historical evidence for declining marginal benefit of cardiovascular disease expenditure as countries grow. So in the US, the next dollar spent on cardiovascular care is going to do a lot less for mortality than in Uganda or in Zambia, where $1 can make more of a difference. And so with declining marginal benefit of spending on cardiovascular disease, the question is, how do you use that expenditure efficiently? And it also seems like we're, in some ways hitting a ceiling, or in different areas are hitting or getting close to hitting ceilings on impact of current approaches. So, we're kind of stuck at like 50% of the population having their blood pressure under control. And it's pretty consistent across developed countries. And so we're kind of maxed out what we're doing with current paradigms for delivering care. And, think about things with the guidelines. We're doing a lot, and we've seen a lot of improvements, but probably we're getting close to seeing all that we can out of current strategies and current protocols for care delivery. And the reality is that pandemics and emerging infections will accelerate over time. And, we have things like climate change that are driving that. And so the question is, how do we then return our attention to areas where there's additional investment needed to circumvent some of the sort of declining marginal returns on what we're doing? One, I think, of course, everybody likes to talk about prevention, and I don't want to just beat that, drum until people are deaf. But I think, doing more on risk reduction, particularly things like tobacco, alcohol, seems to be an emerging risk factor, diet and physical activity, giving those intersectoral policies another look. And even in the US, talking about what we're doing on risk is important, particularly over the long term. And I think patient-centered care, this sort of, movement towards giving patients more control over their care is really great. And I think COVID-19 could accelerate this move towards full self-management of patients, home and community-based care, so they don't need to be going to health facilities as much. They have tools, technologies at their disposal to do a lot more self-management. And of course, this is maybe like a bit of a more controversial statement. Why should we continue to rely on what I might call fragile care systems? If the numbers of interventional procedures done during COVID-19 plummeted for people who clearly had an indication for them, that's a problem. That we are in a situation where we rely on, cardiology catheterization labs to save people from MIs. I mean, and I'm not saying we should not do that, but if that's the only strategy we have, that's a problem. We need to think about how do we then move that out into the community, or how do we do alternative strategies to get to people when they can't make it to facilities on time. And this is just as much of a problem in the U.S. and rural Alaska as it is anywhere else in the developing world. And so I think these sorts of things, again, there's been a lot of harm done by COVID-19, but maybe we could see the potential for good disruptions to accelerate improvements in cardiovascular outcomes and in cardiovascular equity. And I'll just close by giving you a bit of maybe a vision for what this might look like, and particularly through the lens of global health equity. So on this graph, I'm showing you rates of change in deaths 50 to 69 from cardiovascular disease in high-income countries, bottom trace, sub-Saharan Africa, middle trace, and South Asia in the upper trace. And IHME has done projections of those mortality rates out to 2040. And so you see declines in all countries, and some declines, particularly in Asia, that are really substantial, but still a huge gap, a 2- or 3-fold difference in cardiovascular mortality in this age group between countries. And so maybe redesigning health systems can provide opportunities to drive down rates in low and middle income countries to rates that are comparable to high income countries. And so Sub-Saharan Africa and South Asia, maybe we could accelerate those rates of decline to the point where we have reduced inequality in cardiovascular death over time, particularly by not relying on the same care delivery systems that we've been using over and over again with decreasing marginal benefit in the developed world. And so I think about some components to this that might be helpful. The first would be leveraging communications technology. So we've talked a lot about telemedicine. It's not the solution for everything, but it may be a partial solution for cardiology care in Africa, particularly for people who can't make it for transportation-related issues to capital cities. Better use of existing interventions through, like I mentioned before, drone-based delivery and mHealth for self-management. I think importantly, as I talked about in the last slide, new approaches to managing acute cardiovascular disease. I'm not saying we need to build a cath lab in everybody's house, but maybe we can find ways of leveraging technology to do at-home triage and diagnosis of suspicious signs and symptoms. We need to find ways of actually reducing the amount of time it takes to get people to where they need to be, particularly in countries where cardiac cath labs are hours and hours and hours away or days away from where people live. And of course, we have a lot of data here in the world now, big data. And so building dynamic surveillance tools that are actually also disseminated to the population and communicated to people, and coupling that with, better public health literacy around cardiovascular risk. I think these sorts of tools are really, really important for, making sure that everyone in the world understands cardiovascular risk as well as I think we're doing here, or even better. So those are just some thoughts about what can we do in the wake of COVID. I'll just summarize by saying a few things. As I've talked about, there's a lot of concerning trends and increased inequality in global cardiovascular outcomes over time, especially in the last few years, a slowing in progress on cardiovascular disease. But the technologies to reduce cardiovascular disease already exist, and I think there's great potential to use those technologies. And the DCP3 list of interventions, I think, is a really good starting point for doing country-specific assessments and strategizing around cardiovascular programs, and while ensuring good value for money, focusing on services that are going to provide the best bang for their buck. Unfortunately, a number of countries will struggle to meet global cardiovascular targets and benchmarks, and so there's this role for international cooperation, particularly on the technical and financial side of things, and a role for academic cardiologists from the US and other countries. And finally, COVID-19 is creating opportunities to imagine cardiovascular disease everywhere, and I think invites us to take stock about how we're doing things and how better to do them. And I think one last thing I'll say is, again, in global health, people think about cardiology as this sort of expensive, infeasible thing, but I think a lot of our research and a lot of the analysis that we've done in DCP3 has shown that investments in cardiovascular disease are actually investments in the health systems of tomorrow, but they need to be made wisely. We need to focus on the types of technologies that provide great gains and build capacity for the future. So I'll stop there. Thanks again for having me.